Dr. Mary, we're so excited to have you here. You are a board certified OBGYN, but the changes that came with menopause really threw you for a loop. So, going back and reflecting on your time in med school and residency, did they prepare you at all for what women go through when they go through perimenopause and menopause? Like, did they really prepare you?
No, 100% not at all. I gaslit myself in my own menopause. I was like, oh, you're just depressed. My brother had passed away and I was having all these symptoms. And certainly, the trauma of that was, and it, was contributing to what I was going through. But once the fog of that depression started lifting of the grief, then I was like, wait, when was my last period? Hang on. These are hot flashes. I'm in menopause and it was like months for myself. This was my job. I was the expert, supposedly. And so that was kind of the first wake up call that I had was you can't even diagnose your own menopause. It wasn't super clear to me what was going on. And then when I thought back on my training, we maybe got an hour of menopause care, just basic information. It's the end of the periods and she might have a hot flash. That's all I learned in med school. And then in my residency program, which was OBGYN, maybe 6 hours of lectures, no clinics, no clinical experience, nothing to take care of a menopausal patient. I learned about osteoporosis and, some of the real cliche symptoms, but not anything that I know now about cardiovascular disease and metabolic syndrome and libido. I learned nothing about libido, nothing in medical school or residency. That was not even discussed. We got really a very narrow view of women's sexual health or women's health overall. And it really was most of the things that were cardiometabolically linked were that we were small men and we just treat you like we treat our men and you'll be fine.
It's so interesting to me that now hearing, and I've heard you say this on other interviews and now you explaining it here, that there's so much emphasis put on a particular time in a woman's life, primarily pregnancy, right? There's like so much research on there. There's so much information. There's probably so much training that you go through. But really, and I'm a pregnant person, so I can say this, it's a very small part of your life compared to the amount of time that somebody spends in perimenopause, which can be like 15 years sometimes, and then menopause and then beyond. It's like a huge chunk of their life. Why do you think that is?
I think this is a multifactorial problem. It has to do with how society, and this is worldwide, I don't have a single person in any country, and I have a big international following, who's ever come to me and said, oh, we've got menopause nailed. It's like, yep, happening in China. Yep, happening in, Europe. Yep, happening in Australia. So this is how we view aging, I think is a problem, and how we view how females age and the total lack of knowledge and research around how females uniquely age. So you were talking about funding. One of the favorite experiments I do with students when I go talk, I thank God I get to go lecture now at medical schools and residencies about menopause. And I'm actually going to speak at the American College of OB-GYN. They just invited me
Amazing
to go do a menopause talk. So we're getting there. As I'm like, pull out your phones and let's go to PubMed, which is like Google for doctors, and look up these research articles. Just type in the word pregnancy and 1.1 million articles come up. Okay, important stuff. I'm so proud of everything I learned about pregnancy and being able to shepherd a woman through that whole process and get her through safely and everybody's happy at the end. Now type in the word menopause. 96,000 articles right now. Okay, so that number of articles represents brain power, funding, research isn't free, focus, and there's no NIH category, National Institutes of Health category for menopause. It kind of falls maybe under elderly or it's just this vacuum. Type in the word perimenopause, 6,000 articles.
Stop.
That's crazy.
We have a problem. Why is it that the last third of my life is not as important as my reproductive years? Important medically.
That just like blows my mind. And I'm sure you hear this often. We hear it with our customers, even family members and friends. It's like, I just one day woke up and I feel like a completely different person. And I think going back to what you mentioned, a second ago is our lack of knowledge as women to understand what our body's going through. So maybe we start right there. Like, how would you define perimenopause? When does it begin? And maybe we can transition over to menopause because so many of us are unaware of what even happens at that time.
The easiest way for me to explain is let's go way back. So guy is pregnant. All right. And do you know if you're having a boy or a girl or is it a surprise?
It's a boy.
It's a boy. Okay. Well, if you had a girl,
I have a girl though.
so your daughter had her maximum amount of eggs. We're born with all of our eggs. Men make their germ cells fresh. We call them germ cells. There's some spermatozoa fresh every day from puberty till death. Okay. So females are born with all of them. The highest amount we ever have is 5 months in utero when you were 5 months pregnant. And then there's already down to 1 to 2 million at our birth. And then by the time we hit 30, we're down to about 10% of that initial, so about 120,000 eggs on average. And then by the time we're 40, we are down to 3% of our egg supply. Okay, so that kind of puts it in perspective. Okay, so what happens in a healthy reproductive cycle when you're having regular normal periods for a woman? It's a hormonal rise and fall, very EKG-like, right? We have a very predictable rise in estrogen mid-cycle, followed by a decline, another slight rise, and then a rise in progesterone. That is because our brain, the hypothalamus gland in our brain, is constantly checking for estrogen levels in the blood. And when it tests that they're low, it sends a signal to our pituitary gland to say, hey, tell the ovaries to go ahead and start ovulating so we can get some more estrogen on board. And so these hormones are called LH and FSH. Y'all may have heard of these. The luteinizing hormone, follicular stimulating hormone. And so they talk to the ovary. The ovary's like, okay, let's do this. 11,000 eggs get recruited for one possible ovulation. And we lose 10,999 eggs to get one to pop out. But all of those eggs in their process of trying to ovulate are producing estrogen. And then after ovulation, they produce progesterone. So that is a very predictable cycle for most women, every month after month after month. What happens in perimenopause, whenever we reach that critical threshold of low egg supply and low quality, the same signals stop working. We develop resistance to those signals. So the brain's like, hey, I told you we need more estrogen. The pituitary's like, I sent the signal. They're like, send more. So now we get these much higher surges that the timing is off. We can't predict the time anymore. And the stimulating hormones required to force that ovulation are much, much higher, which leads to sometimes 2 eggs being recruited, much higher estrogen levels than we ever had in our premenopausal years. So it used to look like this every month. I'm just kind of showing a wave. Now is a chaotic zone where timing's not predictable and rates aren't predictable. We have these huge surges and then massive falls, and progesterone just kind of really struggles to even get very high, and it's much, much delayed. So that's perimenopause. You go from being able to predict it to a critical egg threshold level where it's much harder to ovulate, and the timing and the amounts really go cattywampus, and it's literally different for every single woman. It's not predictable, which is why we don't have a good blood test for it, or a urine test, or a saliva test, a one-time test. And if your listeners are hearing me say this and someone's trying to have you go in to do all this testing, I'm telling you as an expert, we do not have a reliable, predictable test to predict perimenopause. That diagnosis should be made on symptoms. If you believe the patient and just listen to her and connect the dots. I do blood work. I'm trying to rule out autoimmune disease because it affects every organ system in our body. Where, Yasmin, you might have headaches and not sleeping and gastrointestinal changes, and Kaya, you may have the classic hot flashes and night sweats, but most of us are trained for hot flashes. We know that one, but I never learned about the cardiovascular changes, the insulin resistance, the diabetes, the weight gain, the visceral. I didn't even know what visceral fat was until I went back to school for nutrition. So, there's just this incredible lack of knowledge and education, even on the people who are supposed to be the experts. And I was definitely one of them. I was a terrible menopause provider for probably 20 years.
Well, it comes down to, I think, what you were saying, what you were taught in school and how you guys were kind of taught to view women at that particular stage. I know when I was growing up, I just thought, okay, my mom went through menopause sometime in her late 50s, 60. I don't remember. That's in the future. I don't have to worry about that. I didn't even know there was such a thing as perimenopause, honestly, until probably I was in my 20s, maybe. And we're talking about a big chunk of time that women can start to notice these shifts. So I know it's different for everyone, but when can those shifts start in a woman's life?
So the average age of menopause in the US, at least, is around the age of 51. And that's mostly for Caucasian women. Asians tend to go through a little bit older, whereas African-American and Hispanics tend to go through just a little bit younger. Perimenopause, remember, when the force gets disrupted, usually begins 7 to 10 years before your periods actually fully stop. So if you do the math, and so average is 51, but normal still 45 to 55 for full menopause. You're done. The eggs are out. There's no more, the factory is shut down forever. Then back that up 7 to 10 years. So 35 to 45 is when a woman will start noticing something's not right. It's usually retrospective. They couldn't put their finger on it when it was happening, but they just felt different. And there was a beautiful study that just came out saying, I don't feel like myself. And they like broke down what that really meant for women. And it's usually perimenopausally related and heavily related to her mental health.
What should women in their 20s and 30s? I'm 37, so I want to start to think about this because a lot of the women in my life who are in like 42, 45, they really feel bamboozled. They feel like nobody told me any of this, and I feel I can't sleep. My libido's all over the place. My ears are itchy. I'm getting weird symptoms. I don't know what's going on with me. Like I'm gaining weight. So what should women in their 20s and 30s really start to think about at this stage to help navigate that later stage?
I have one of my favorite talk. I tell my kids, like, what would I do differently now that I know what I know? What would I wish I would have known at 35? And one is nutrition over calories. I was a child of the 80s. I moved my body to be thin. My self-worth was based on what I looked like, and that number on the scale controlled my life, even though I was thin. And that was just so wrong. I probably chipped away at my bone and muscle strength in the effort to be thin by caloric restriction and only doing cardio. I didn't pick up weights till my 50s, not seriously. And so now that I know what I know about dementia prevention, cardiovascular disease prevention, frailty prevention, which is so huge for, when my patients come in at this age, they're like looking at their mothers and saying, I don't want to be on a walker. I don't want to be in a nursing home for all this time. I don't want to have cognition deficits or dementia or Alzheimer's. What can we do now? And so these are the things your listeners, the younger listeners, the millennials should be paying attention to. Nutrition over calories. Stop counting calories. Don't worry about that. Fill your body full of anti-inflammatory foods, full of fiber, full of protein. Make sure you're hitting your micronutrient goals. This is critical to your bone and muscle strength, which is going to be critical to your overall health as you get older. Don't sweat your curves. For God's sake, I tell my children, that is genetic. That's beautiful. There's nothing wrong with subcutaneous fat. We all have it in different places. We can't let society define our health by what we look like. That is just not a healthy way to be. And you're going to end up worse off in the long run. Strong over skinny. Strength is so important. Rock those muscles and break. If you were born with great muscles, hang on to them. If you weren't, you can build them, but it's going to take a whole different mindset than going to cardio all the time or just really focusing on getting stronger. Educate yourself about menopause. I wrote the book for you, learn as much as you can. This 100%, if you live long enough, will happen to you, and it will rock your world in ways you will not realize unless you arm yourself with information. And sadly, you're going to have to fight to advocate for yourself in our current healthcare system because we're not training our providers, and we're a generation away, by having, you can confidently walk into your healthcare provider's office, family medicine, your primary care doc, and have an informed conversation about your menopause. And so for those of you in your 20s and 30s, by the time you're menopausal, maybe, but you're better off learning yourself because you may have to educate your healthcare provider.
I love this. We have so many people. We have a company called beeya. It's in women's health. And we have women older who are like, man, if I only knew this when I was younger, if I could just tell the 20 and 30-year-olds, take care of your hormones, because so many people don't even know what hormones are. They're like, oh, I kind of have a bad period, but we don't really, we think it's normal. So I'm so happy you're bringing this up, because so much of what we do in our early years can set us up for success, later for perimenopause and menopause. So I love this. And actually, I want to talk about a stat, which I was mind blown about in another interview you mentioned, where 50% of women will have an osteopathic fracture. What is that, after 65? But can you talk about it? Because I feel like it's so common. Like you said, you see your mom or your grandmother fall, and then it's just downhill. And I think this is really important for us to talk about.
So 50% of women will have an osteoporotic fracture before they die. And if that fracture is your hip over the age of 65, you have about a 30% chance of death in the first year. And that's with surgery. That's with surgical repair. You don't repair it surgically, or you're not, my dear friend Vonda Wright, who's an orthopedic surgeon and just does menopause, fixes hips all the time. She says it's just devastating when someone is not well enough to survive surgery, and she knows she's going to die, within that year from all the complications from the hip fracture. And this is preventable. We can prevent 50% of these fractures. And so, we don't have to fall and break, but we reach our maximum bone density naturally and muscle strength typically in our 20s to 30s. And then it's kind of a slow decline until our menopause transition. And then it starts accelerating like crazy. So kind of where you're starting is going to help determine if you cross that disability threshold. And all of this, my generation of women, I'm 55, who were only doing cardio to be skinny, I'm seeing the downside of it where they're coming in with osteoporosis. So sadly, our healthcare system is not paying for most women to have a bone density scan until they're 65, and the cow is out of the barn for most of us at that point. And so I would tell your listeners, the minute you figure out you're somewhere in your menopause, pay the $99, go get a bone density. There's all these little pop-up stands now. You know your risks because you can intervene. And the earlier you intervene, the lower the chance of these risks are going to be happening. Hormone therapy is a big part of it. If you follow me, I wear a weighted vest all the time. I do housework. I walk the dog. I, wear on my treadmill. That is a hack for helping to send that signal to the bones and muscles, like jumping up and down is a signal, all these little tricks that we can do to try to send that stimulus to hang on to that bone.
This is something I'm so passionate about coming from a South Asian background, because a lot of the women who are my mom's age, my aunts and the people of that generation, they didn't work out really. They were doing a lot of housework, but they didn't do any sort of strength training. They weren't really eating a protein-rich diet. It was a vegetarian diet, really carb heavy. And now I'm seeing it with my mom and, all of her peers, just like osteopenia, osteoporosis, having hip replacements, having knee replacements. And it feels very scary to feel, okay, you're only in your 60s and you're already having mobility issues. And so I'm on a mission for that particular population to kind of get them to overhaul. Hey, we need to really be thinking about what we're eating and how we're working out and everything. I want to talk about this subject of visceral fat. So I don't know if a lot of people know what visceral fat is, but you talk about it a lot. It's something that women who are going through menopause, they see an uptick in visceral fat at that stage. So what is it and why is it dangerous?
So visceral fat is the fat that is deposited in and amongst our abdominal organs. So different than subcutaneous fat, which gives us our curve. Subcu means under the skin. Okay, so that's your breast, your butt, your hips, your cellulite. We don't like it. It's cosmetically distressing, but it really is not. Unless you have a lot, it's not that dangerous. Visceral fat is the fat that is in our omentum, which is like a little sheet that wraps around our internal organs for protection, but it can become very fatty. The fat all through our bowel, our fatty liver disease, it can wrap around the heart and cardiovascular disease. So that visceral fat is much more dangerous. It is much more biologically active and it's pro-inflammatory. And a woman average has 8% visceral fat of her total body fat pre-menopause, and that turns into 24% postmenopause with no changes in diet and exercise. So the loss of estrogen, the changes in testosterone, the changes in progesterone are contributing to this increase. So a woman who goes through menopause, so say we have two 50-year-olds, one's menopausal and one's not, and they're identical twins. Just make this up. Go there with me. She has a 3 times higher rate of metabolic syndrome, which is the combination of hypertension, diabetes, insulin resistance, and chronic inflammation, just from being a menopausal person. Like, these are the things that we're not teaching our medical students and our healthcare providers, and our clinicians. We are dumping this in the lap of the poor, busy OBGYN, because I was her. And why should she be completely in charge of all things to do with a woman's health? She should really be doing what she does now. This should be taught to internists, surgeons, anesthesiologists, how as females, as aging females, we require different levels of medications, different considerations. If you look at the data on cardiovascular disease, okay, we enjoy a much lower rate of cardiovascular disease than men until we go through menopause. And after about 10 years, we start passing them up. So the number one thing a woman's going to die from is cardiovascular disease. And the only medication to date that has been shown to decrease the risk of a primary heart attack in a woman is not statins for cholesterol. It is HRT. If you begin within the first 10 years of your menopause, there's protection on top of just treating the cliche hot flashes, which is why MHT was developed, was just to stop hot flashes.
No, that stat is so mind blowing. I've heard you say it before and I'm so fascinated by it. I know that you're obviously not giving medical advice, but can I give you a hypothetical situation and you would tell me if that would be a good candidate for HRT? So essentially, you're saying within the 10 years of beginning menopause, this hormone replacement therapy can be cardioprotective in a way that maybe statins are not shown to be for women. So let's say there's a woman who has a history, and we'll talk about people who are a good candidate for HRT and who are not, but a history of hormone related cancers in her family. So breast cancer in her family, but her mammograms have been great, nothing showing abnormally there. She's has high cholesterol, but done all the CT scans, clearly scans, things are looking good. There's no like buildup of plaque. Would someone like that, because I imagine that case of having,
she's the best candidate because estrogen therapy in the WHI in the estrogen only arm had the 30% decreased relative risk, which is, of breast cancer. And the women who were on the combined therapy, estrogen and progestogen, had lower stage and better prognosis and lower risk of death than the women diagnosed not on HRT. So, these are the stats I talk with my patients about when we're weighing stuff. But family history outside of like having a genetic mutation like BRCA, there's no increased risk over placebo for a woman with a family history. You're probably better off if you get in that window of opportunity. Estrogen doesn't cause breast cancer, does not.
That's good to know. And I think, zooming out, there's so many misconceptions around what hormone replacement therapy is. So maybe can you talk about that and why is there so much fear around it?
So hormone therapy is replacing the hormones that your ovaries no longer make, either during the menopause transition and then after. So those hormones are estradiol, your estrogens, your androgens, and then your progestogens. So estrogens, body identical, which is more of a marketing term, but people understand it. The one that is chemically identical, is estradiol. And in the menopause, the people I trust the most, to do the right thing for patients, we pretty much all that's our primary go-to formulation is I just want to give her back the water she was drinking. We know that she was healthy for all these years with estradiol. Why would I not give her that? Why would I give her something synthetic, right? Unless she doesn't tolerate certain things. I'm glad we have options. For progestogens, we have the synthetic progestins, which good, bad, ugly, and then we have progesterone, which is really best delivered in the oral micronized form. Not everybody tolerates that. Some people have like a hangover in the morning and, or have a reaction to it. So then we have the progestins that we can try, or just skip a systemic progestin and do a progesterone containing IUD to protect the lining of the uterus. Lots and lots of options, very nuanced conversations. Androgens, pretty much we give testosterone. Testosterone, we know it helps with libido. Studies are very clear. Sadly, the FDA has horrifically not approved it for women. Again, another problem on multiple levels. And the safest way to deliver testosterone for all humans is transdermal. There is an oral undecanoate. I don't think it's available in the US. We don't use that here. So we pretty much stick to transdermal options here in the US. So those are kind of the three main categories. Why are people scared of it? One study that changed the face of women's health for 22 years. A study that was grossly overblown, that was grossly misinterpreted, and that has caused more harm than good. Now, there's good data that came out of that study. I love the data on protein and frailty. They studied lots of things. It was developed to see if we've known for years that estrogen was protective for cardiovascular disease. The observational data was clear on that. But they wanted to do a randomized control study, which is the gold standard, to say, what were these women having less cardiovascular disease because they were wealthy and healthy, which is, women who were getting HRT tended to be higher socioeconomic level and look like me. Or, was this just artifact? Because of that, is this real? So they developed this study. The average age in the study was 63 years old because women don't get heart disease till later. And so they chose an older population because their outcome was whether or not they died from a heart attack, or developed cardiovascular disease, which at the time there was no screening. Remember, the calcium cardiac score is new. So back then it's like the only way to know if you had cardiac disease was a stress test or you had a heart attack. So they started older. They stopped the study because they found in the estrogen and progestin arm, which the only medicine they studied is not really used today, was Premarin or Prempro. Okay. Premarin if she'd had a hysterectomy, and then you have to add in the progestin if you still have a uterus. So they weren't using modern formulations, that we use today. That was what was used back then. It was totally reasonable that they used that.
Sorry, was that estradiol or that was not?
Premarin, which is conjugated equine estrogen, CEE, in the literature, if you read it, which comes from pregnant mare urine, which is a rich source of estrogens. So that's a whole nother talk on formulations. But we don't really use Premarin that much anymore. I don't, and the people I trust don't either, as a primary go-to. So the estrogen-only arm, they didn't have any increased risk of breast cancer. So it turned out it may have been that particular progestin that they were using in that formulation that was likely related to, this very slight. So the relative risk was 25%. It was 4 out of 1,000 per year to 5 out of 1,000 per year. Okay. Versus placebo. Women get breast cancer because we have breasts, and probably genetic things and environmental things and all that. But the addition of the hormones only increased that, but that was a 25% relative risk increase. Absolute risk per year per woman was less than 1% versus placebo. But the headlines, it's why things go viral. So the researchers held a press conference at the Watergate Hotel in DC, and everybody was there. And it was on the cover of every newspaper. It was on every talk show. It was on all the news stations. Estrogen causes breast cancer, 25% increased risk. Nancy Snyderman on, I think it was Good Morning America, got up and said, I took my mother off. I would never take it. And everyone was terrified. Women threw it in the trash. 80% of prescriptions stopped immediately. And we stopped prescribing after that. That was the last year of my training. I was terrified of this. Well, that study has been re-examined, looked back, walked back. No one's talking about it. They're still stuck in 1992, or 2002 when the results were released. They started recruiting in 1992. This is 30 years later, we're still asking the same questions, like women deserve better than this. And estrogen is not nearly as and no one's ever talking about what are the risks of not being on HRT. It's almost like the epidural. It's like the way I felt about an epidural is the way I felt about hormone therapy. I was going to see if I could tough it out, and sure enough, I got an epidural at 3 centimeters and was like, no. But hormone therapy, I really dragged my feet starting it because I was so scared based on data that was taught to me in 2002 that the American Board of OB-GYN, I'm calling them out here, had never presented all the walkbacks, all the pros about estrogen therapy. I couldn't have an informed conversation with myself. I felt like I wasn't tough enough to survive the sleep disruption and the hot flashes, so I had to take this HRT. And that's when I started digging. Something's not right here. And I felt so good. I realized I was suffering from multiple other things I just attributed to aging that suddenly got better. My joint pain, the quality of my sleep, just my relationships, my mental health, all of it was so much better. And I'm like, wait a minute. This is a much bigger picture that has been presented to us.
Yeah, it's kind of incredible. I think the unintended consequences of that Women's Health Initiative study were far reaching. Like even growing up, me thinking that estrogen was like a bad thing, just overall, even in my body, I was like, oh, if you have too much estrogen, it's a problem. I mean, obviously estrogen dominance is that's a real thing, but like me not even understanding what the benefits of estrogen were because I had it in my head that, oh, if you have too much estrogen, you're going to get endometrial cancer, breast cancer, ovarian cancer. And like, that's it. And not thinking beyond that. And even having those conversations with my mom recently after we listened to your podcast with my brother and her kind of sharing, oh, well, my friend was on hormone replacement therapy and her doctor said that she got cancer because she was on it. And, those types of stories just.
Right. I've heard that so many times. And that is such a terrible thing that women feel responsible for their breast cancers because they chose hormone therapy. And they, so few women, only 6% of women are on it right now who could have it. And that they were made to feel terrible because they chose to like not suffer. And then they gave themselves breast cancer. And that is not the case in the vast majority of cases. But I mean, there are oncologists today telling patients that. So we have a very long way to go in changing this mantra and educating everyone.
Yeah. And I'm so excited those conversations are starting. So if anybody's listening to your work, which has exploded over the past year, like I just love to see it. It's amazing. I love to see all the TikTok videos and the Instagrams. If people are listening to you and they're like, okay, I think she's talking about me, I need to look into this. What steps should they take?
I wish I could tell you just call up your doctor and make an appointment to go discuss these things, but you only have about maybe a 10% chance of finding someone that way, just random, who is menopause educated, who knows. I didn't know enough, to be an effective menopause provider. So I became certified. So one way is the Menopause Society, menopause.org, has a fabulous database of theirs. You want certified provider, the ones who took the test, because they list all their members. Not all are certified. So make sure you look for that certified check. I'm going to start training. I'm developing a training program out of necessity. People are begging me, please teach me what you do. And so I'll have that launched. And so we'll have a site on our website with certified providers, just so I can teach people how to provide menopause care, because it's just so needed. And I can't be everyone's doctor. I have a waiting list of 2 years right now, which is ridiculous,
So just talking about the last question I have around HRT, maybe at a high level, unless you need to go more into detail, who do you think is a good candidate and maybe who wouldn't be a good candidate for it?
So let's talk about who's not a candidate, because the vast majority of women are perfect candidates for it. You are not a good candidate if you have undiagnosed vaginal bleeding. So you have some weird wonky bleeding, usually heavy, or something going on. You need to get that evaluated before you start HRT. We don't want to feed a tumor that estrogen might kind of promote its life. So that could be an endometrial cancer. So we're always worried about you have an endometrial cancer, and then we're giving you estrogen on top of that in the postmenopausal phase. So you need to have any postmenopausal bleeding or abnormal bleeding worked up before. That's the biggest thing. If you have severe liver disease, where you have constantly, very elevated liver function tests, estrogen is processed in the liver, metabolized mostly in the liver and then excreted in the colon. So, through bile, and you really, really, really are not going to process estrogen correctly if you are with severe liver disease. You're not going to be a candidate. If you are being treated for a blood clot, estrogen is not recommended until your treatment is over. And then there's a nuanced discussion around what therapeutic options are there for you if you have a personal history of some kind of a blood clot or stroke. Okay. Those, or any kind of tumor that estrogen would feed on, could be a breast tumor, whatever. So that would feed on estrogen. So those are really the big contraindications. So that is not most women. So a lot of the misconceptions are, a lot of, women come to me on social, or my patients are like, well, my doctor told me I couldn't take it because my third sister's cousin's brother had a blood clot, and we have a family history of blood clots. And I'm like, all oral estrogen will increase your clotting risk, but not transdermal. So unless you're actively being treated for a blood clot, you absolutely, if we just use a transdermal option, then we can avoid increasing that risk. Your risk is elevated because of your family history, but I'm not going to make that worse by offering you appropriate hormone therapy.
This is such good information, I think, for people to even start to think about if they're a good candidate, what can they do? I just love that we're having this conversation.
Just think about it. If this happened to men, if at 51, their testicles shriveled up and died on average, and they had to live the last third of their lives without the benefit of their sex hormones, what do you think would happen?
I'm laughing because it just wouldn't.
If it shriveled up to the size of a sausage and was really painful every time he wanted to have sex, and he was depressed and anxious and, not sleeping and, restless legs and had tinnitus and ringing in the ears and itchy skin, we wouldn't have this conversation. This would not be a thing. It's hypogonadism. It is the loss of our sex hormones. Yes, it is a natural process, but it can cause tremendous suffering, and it accelerates our risk of disease states. And we're just replacing. It's like you have hypothyroidism, or you have insulin, your pancreas won't make insulin anymore. We would give you back those hormones so that you could function properly. Now, you can choose not to go that route, and I respect that. Your body, your choice. But women aren't being granted the balanced conversation on the benefits and risks. There are risks to being on it, and there are risks to not taking it. And they're not having the second half of the conversation.
That's such a good point. I never thought about, okay, if you had a thyroid issue, you're getting thyroid hormone. If you have a pancreas issue, you're getting insulin. And I saw a conversation recently that was happening online that I think that you were a part of too, where somebody had posted a meme saying something like, oh, it's not your hormones, like you're eating too much or something like that. Somebody had posted some crazy thing. And this issue. This
It
conversation.
wasn't Lane. He kind of blew it up as one of his followers, and he kind of reposted it. And
Yes,
we
yes.
had a discussion offline.
Oh, good. I'm glad. I'm so happy to hear that those discussions are happening. But somebody else had said in the comments, well, instead of throwing hormone replacement therapy at it, what we should be asking ourselves, what are women doing that are leading to this? And I just thought to myself,
Breathing.
right, right, right. And it's like, why, when it comes so specifically to this particular thing of women having fluctuations or drops in hormones, is it so triggering for society to accept that maybe we need to take a medication or
One,
something?
I don't think most people understand that we were born with a limited egg supply, and it is programmed genetically to run out before we die. And now that hopefully this book, that information will get out there, and they'll understand that I didn't do anything. Certainly there's environmental things that can speed up the process. If you smoke, if you've had chemotherapy, if you've had hysterectomy, if you've had any abdominal surgery, any inflammatory process in the abdominal cavity increases the age or decreases the age at which you will go through menopause naturally. So it depends on how many kids you've had, if you've had too many kids or not enough kids, or, so if you've been on birth control pill, you get a couple of, a few more months with your eggs because you weren't trying to ovulate during that time. But imagining that automatically the perimenopausal process has something to do with you being a bad person or food choices. PCOS, yes, we know that there's a huge nutrition component to the treatment of PCOS, but you're born with that insulin resistance. You were born genetically predisposed to this. And these are the conversations we need to have, and stop shaming women. Education can put an end to all of this. People who are saying stuff like that don't understand endocrinology and should not be talking about it on social media because it's harmful.
Amen.
And I'm curious, I didn't follow it too closely. Kaya was giving me like the deets high level, but
Play.
yeah, the play by play. I'm so glad that you guys had a conversation offline. Like, how did that go? Was it just like a misunderstanding? Oh,
No, we did not have a person-to-person conversation. It was a very roundabout.
Got it. I thought it was like a conversation over the phone to like talk through details. I'm like, oh, that's lovely.
No.
But I honestly, I'm all about that. If the opportunity ever presents itself for two people, one person who has experience with it and one person who feels they have experience with it, to have a debate, I'm just saying I'm here for it, because I would love to hear truthfully, like, two people actually hear each other out and kind of bring their experiences to the table, which I think needs to happen more in this space.
I agree.
I want to go back to the topic of visceral fat. Two things that I've heard you talk about that are really critical for decreasing visceral fat are increasing fiber and decreasing added sugar. So can you talk about those two things?
So when I was scouring, the research studies and the data for menopausal people, okay, not 25-year-old male athletes, which is where most of the data comes from that a lot of these health gurus talk about. So when I looked for data for my people, and what I found was there were definite nutritional trends that led to lower incidences of visceral fat accumulation. And one was fiber. Women who consistently got 25 grams or more of fiber per day, and it seemed to max out at around 32 grams, have lower rates of visceral fat. That leads to lower insulin resistance, lower diabetes, lower cardiovascular disease, all across the board, all metabolic syndrome, just from fiber intake. Now, that doesn't mean that you can just eat whatever and take a bunch of fiber supplements. That is not how that works. The women this was studied looking at fiber intake from food, from whole food, from nutrition. Turns out those foods are rich in a ton of other awesome things like anthocyanins and vitamins and minerals and nutrients. Like, it's packaged perfectly. And so, yes, I'm a doctor who sells supplements, so full disclosure, and fiber is one of them. But, I'm always like, that fiber should come from your food. We just supplement if there's a gap, you have a bad day, you couldn't get to it, but if you can hit those goals with your food, you're going to be better off. We don't take supplements to undo poor nutritional choices or sticky situations where we're stuck and we can't get to the food. Travel is the worst for me. So the another trend was women who limited their added sugars added in cooking and processing, not fruits and vegetables, not dairy, okay, not naturally occurring sugars, and alcohols in the process too. Limited those to 25 grams or less per day. That's about 4 teaspoons, okay? Much lower rates of visceral fat than not. And the Western diet, unfortunately, is very low in fiber and very, very high in added sugars, usually around 100 grams per day instead of that 25. So those two things alone can really turn the needle for patients and really, really be helpful if they're not already doing that.
You know what I want to talk about is alcohol. Tell us more about your thoughts around alcohol when it comes to women versus men.
Well, we know that our tolerance is lower, and at least, I'm digging through looking for more studies on this. From 90% of my patients, the tolerance through the menopause transition and beyond is much lower. For myself, I've noticed if I choose to have more than one drink, especially if it's later in the evening, forget it, but more than one drink for me, I'm choosing not to sleep. It's so sleep disruptive, meaning I can go to bed okay, but I am waking up at 2, 3 in the morning, sweating, dreams, all the things. And I talked about it on social media one day and like thousands of comments. Oh my God, me too. I quit. I don't even drink anymore. So and I looked into it, and it seems to be something to do maybe with our body composition changes. Like we lose muscle mass, we gain visceral fat. That seems to be a part of it. Our brain totally rewires through the menopause transition. We see mental health changes, our dopamine and serotonin levels change, and our cognition really changes. And so alcohol just is having more significant effects on us, especially as we age and especially in menopause. And so, I'm having serious conversations with my patients about, have you considered getting sober curious? Because it never served us probably before, but it is really not serving us. So, she's persistently can't sleep or doing that 3 a.m. wake up. We're having serious conversations around alcohol.
Yeah, it's so interesting. I know a few people who have the sleep issues and, might be in that perimenopausal phase, but are having that wine at night to kind of like relax and sleep. And I'm like, that's doing the opposite thing. So I'm glad you're preaching that, because I've definitely noticed a significant change in alcohol, and 35, I'm like, it's just not worth it. I don't function as well the next day. So it was very easy for me to put aside, and maybe I'll have one drink here or there for a celebration or something. But I love that you brought that up.
I want to talk about the weight changes that happen at these stages. I was talking to my mother-in-law, and she said something that a lot of women say at that age, and then also younger too, I hear, where they say, gosh, my husband will just give up like cupcakes for a week and he drops weight, and I am doing the most. I'm barely eating anything, and I am gaining weight. So how do women navigate the changes that happen in their weight as they get older, when things that used to work aren't working? And from what I see, just eating less is definitely not working either.
Right. So that was my whole first book. That was my whole toe in the water was my own frustration with weight I couldn't get off. I knew I'd gained part of it through the grief and just eating carbohydrates nonstop through my grieving process, and stopped working out. I knew that I was eating too much and not working out enough. So when the grief lifted and I was like, okay, let's get back to your healthy, skinny self. What did I do? Worked out more and ate less, worked out more and ate less, worked out more and ate less. And all of a sudden it wasn't working anymore. Like I'd lose a pound or two and it would just right back on, And I'm like, this doesn't make sense. I know how many calories I'm eating. I know, like I'm a doctor, like they told me this has to work. And I've told patients for years that maybe they were underestimating their calories and overestimating their calories. And then I was like, no. I'm calorically restricting to dangerous levels, and it's still not sticking. I don't understand what I'm doing. I was ruining my metabolism, chewing up my muscle, all the things that I know now. So we know that when we just look at the number on the scale, which is the worst thing we can do, it goes up regardless of whether you're menopausal or not. Women tend to gain weight as they age, okay? But what is happening is the body composition changes. We are accelerating our muscle loss and accelerating the visceral fat gain. That muscle is our basal metabolic rate. That muscle is our resistance to insulin. That muscle is so important metabolically. It is the sink for our glucose. And when we lose it, things don't work as well. Now we're also building up this inflammatory organ inside of our abdomen, which is pumping out cytokines, making things harder. We've lost the estrogen, which was a powerful anti-inflammatory. So this whole menopause transition, we end up in this negative feedback cycle where so many of the traffic circle, so many of the inputs were all, we lose the estrogen, we have increasing inflammation, and everything is feeding into each other. So, and it just, people are like, oh, that makes so much sense now. It's not that you're lazy or you're not working out hard enough. Just what you relied on in your 20s and 30s for the vast majority of us will no longer work for homeostasis because we've changed on the inside. So we need to change what we're doing for most of us.
that's such a good point that I want to reiterate and make sure that I'm getting right. So essentially, when we are under eating, our muscle is wasting away, but our muscle is the thing that's going to make our bodies able to handle more calories. So the muscle is the thing that we need to be able to eat more and be leaner or maintain like the weight that's healthy for each individual person, essentially is what you're saying, right? So how do women, particularly, at any age we should be thinking about this, but how should they shift or think about their macros to support muscle building?
Protein centric, protein forward. Gabrielle Lyon says it best. Stacey Sims has a lot of information on this. These are like my go-to people that are like have lived their lives for this and know all of the research. But we as females tend to massively undereat protein. FDA is only recommending 0.8 grams per kilogram of healthy body weight, and most women know their healthy body weight per day. The WHI study, amazing data on frailty, 1.3 to decrease the risk of frailty by 30%. And people who had the highest bone density and highest strength scores was 1.5 to 1.7. So double what the Food and Drug
Of your
Administration
body weight?
is of. So I do it in kilograms because science. And but so say you weigh 100 kilograms is your healthy weight. You have to do the math, take your weight divided by 2.2, your healthy weight. And so you want to be eating 1.5, so that would be 150-ish grams of protein per day. So for me, at my weight and my healthy weight, it's around about 100. So my goal is about 100 grams of protein per day for me. I calculate that out for my patients when they come. I have a body scanner. I can measure muscle mass and all that stuff in my office. So I calculate that out for them. So like treating protein is the most important thing. And then filling around that with your plants is really the healthiest way to go, at least for us. But like, I never thought about protein before. I was just counting calories and trying to avoid McDonald's. I thought because I didn't eat fast
You were
food,
healthy.
then I was healthy, but I didn't understand. I wasn't getting any magnesium or vitamin D, and so protein is really going to be key, and doing the resistance training. So picking up some weights, hiring a trainer, going on YouTube, finding a resource, because most of us don't know how to do it and are super intimidated when we go to the gym. But it's never too late to build muscle. Study after study after study done in the elderly, 65 and older, showing increasing bone density, increasing muscle mass, but you have to push to do it.
I'm just thinking about that number you shared, and gosh, there are very few people who are getting the amount of protein that they need, which I think is shifting in some ways. A lot more people are talking about it. Like you said, Dr. Gabrielle Lyon and Dr. Stacey Sims are sharing so much beautiful information about the importance of these things. But I mean, even on a day-to-day basis, like I have to be on top of myself too, and I know about this stuff, and I have to stay on top of it.
Same. I mean, I count, the only two things I track really are fiber, because I know how much vitamin D I'm getting, are fiber every day, and protein, because those are like, if I can hit those, everything else falls into place. I weigh now on the scale, the number on the scale, and it still freaks me out a little bit because 50 years of like brainwashing, more than I did when I started Galveston Diet, when I was at my frustrating weight. But my body composition's totally changed. I put on like 7 pounds of muscle and lost 10 pounds of fat, And so, but still, you still have that, when you see that number on the scale, even though I'm now the expert in this. And it's hard to untrain your brain from that.
Oh yeah, for sure. But I'm sure that at the same time, you think about how you feel, and hopefully that's like the reminder there. Like,
right.
Oh,
I look at my mother, who right now, well, she's having horrible end stage dementia, but she's been on a walker for 10 years. She was a college athlete, and, she's a lot of bad habits that I'm trying not to, there's a lot of things contributing to that, but I don't want that. I don't want my kids who are 20 and 23 to have the conversations my siblings and I are having right now about, Mom, what do we do? How do we fix this? What's the next step? That's really motivating for my generation, is watching the elders and what they're going through, and how can we, not that I don't mind suffering, I guess, because I'm a woman and it's just part of how I was built. But, I don't want my children to watch me suffer and then feel like it's their responsibility to fix it.
Yeah. I think that Yasmin and I feel that. I'm sure we're going to feel the way that you're feeling. And right now we're feeling I don't want my kids to go through like the horrible periods, like all those estrogen dominance, all those things that I dealt with that I had no idea had anything to do with diet or stress or lifestyle. And so it's like, we're all doing our part for our kids, right? Like that's the big thing right there.
What I love so much, Dr. Haver, what you mentioned is like you didn't start doing all this until you mentioned you were 50, right? Like you started strength. Like that is incredible to hear because sometimes people have so much shame around, dang, it's too late. I'm just going to be like this. Like
Never
I
too late.
love, yeah, that it's never too late. So
Never too late.
I know we're kind of coming up on time, but I just wanted to end with maybe one final note on stress, because from our understanding of with other experts in this space, that essentially once your ovaries crap out, your adrenals kind of take over, right? Stress is just a part of our daily lives. There's no getting around it. But I think unmanaged chronic stress is becomes an issue. So any last sort of tips for women who are kind of going through this stage around stress?
Put your oxygen mask on first. Put up, you need boundaries. If you have unhealthy things in your life, whether it be relationships, habits, whatever, really look hard, because your resilience is dramatically changing through this transition. And who is going to take care of you? For me, it was meditation and journaling. I thought that was woo woo. I was too high strung to do any of that. I would lay on the floor in Shavasana and be like, oh, I can't do this, And now it's like I've just learned to put myself first, prioritize that time, just carve out that time where I'm dissociating from everything. For other people, it may be calling a girlfriend, it may be prayer, it may be, but find that thing that is going to take you out of yourself and help you self-regulate. That's just such a huge thing. I can't, I tell my patients, I can't change the fact that your mom's dying or you're getting a divorce or your kids are driving you crazy, but like what we can work on is how you manage that. And so let's talk about some strategies around that might work for you.
That's so important at any age. If we can start learning that, that's something I think about all the time. In our 20s, 30s, we'll be good in our 40s, 50s, 60s plus. So I love that. Stress management is always like a key theme with all the experts we have on here when it comes to women's health. But oh my gosh, Dr. Haver, you are amazing. Let's just end. Where can everyone find you? We know you have all this incredible content, so would love for you to share.
So we have a website called The Pause Life, and we have tremendous resources there, all free. Blogs on everything to do with menopause, how to find a doctor, lots of, quizzes and things to help you, tools to help you. And then on social, if you just Dr. Mary Claire, pretty much everywhere, you'll find us.
Thank you so much for being on here. I can't wait to get this conversation out. And yeah, thank you.
Thank you.